Namaste. This presentation is on tuberculosis and its treatment. Tuberculosis is an ancient disease and is relevant even today also. The number of infections is in billions and the number of deaths is in millions. The 2020 statistics mention that 10 million people were infected and 1.5 million deaths were there. This disease is caused through Mycobacterium bacilli, which is a special type of organism. The speciality is with regard to its cell wall. It has got a waxy mycolic acid cell wall which is resistant to alcohol, acids, and once it is stained with a dye, it cannot be washed with acids. That is why it is also called as acid fast. That is with regard to the structure of the organism. Depending upon the site of infection, mostly it is pulmonary all the time. Otherwise, there are two more other places or organs where it can infect the human being. That is, one is pulmonary, then urinary system, including genital system, can be infected, or if the nervous system is infected, it is called as tuberculosis, meningitis. Then there is one more very severe type and dangerous which will surely cause death is if the tissue is injured and if the organism enters the bloodstream, then it is called as miliary, miliary tuberculosis, and it is widespread. It can infect various organs in the body. It is highly contagious. Let us look at the symptoms. The symptoms are coughing for more than 3 months, blood, mucus, chest pain, pain while coughing or breathing, and fever, chills, night sweats, loss of appetite, and weight loss. The damage that it causes to the lungs is permanent. And in some cases, there can be nail clubbing may also occur. That is also one of the symptoms. It is Robert Koch who identified this organism on March 24, 1882. And he got the Nobel Prize for this in 1905. And even today on March 24th, it is celebrated as Tuberculosis Day. When it was found out by Robert Koch, there was a confusion because it was the same organism which was there in the cattle milk also. So there was some confusion whether how it could be there in the animals also. Later on, it was found out that by preventing this taking the milk product from the cattle, you could reduce the transmission. So the pasteurized milk drastically reduced the transmission of tuberculosis. And BCG, all infants, we all have taken BCG, and that BCG is B stands for bacilli, C stands for Albert Camet, Calmette, and Camille Guerin, Guerin. That C is for Camet and G is for Guerin. B is for bacilli, BCG vaccine. These are the two scientists who developed the vaccine. And once vaccinated, its effect lasts for 10 years. After 10 years, it starts diminishing. It's the induced immunity is diminished after 10 years. Let us look at the way the infection happens. Any infected person, if he coughs, sneezes, or even talks, the droplets can go in it is an airborne disease. And once even if it is in the desiccated form, if it enters the respiratory system through the air sacs into the alveolar macrophages, it enters the alveolar macrophages in the lungs and it starts developing there. That means it starts replicating. Then the macrophages, they identify that there is a foreign body in our system, and through phagocytosis, they try to eliminate this. Then these are converted to phagosomes, phagolysosomes, and they use the cell uses oxygen, acids, everything it tries to eliminate the infecting organism, but they fail. Then what happens is the mycobacterium tuberculosis, it starts growing, it reproduces in the macrophage, and it grows and it kills the immune cell. That is the end of the immunity. Then the lymphocytes, they surround the infected macrophages and they form the tubercle. That is why it is called as tuberculosis. Then what happens is our system also cannot destroy these organisms because of the protection that they get. They form a granuloma, they form the tubercle, and they totally avoid our the host immune system is totally evaded, and the organism can lie in a dormant state for years together. So that is the story of how the infection happens. So as we can see, it is through respiratory system and it is airborne. You need not come in contact also, and even if it is in the desiccated form, it can still cause infection. And the worst part is it is slow growing and it can remain in dormant stage for years and decades. Now, how the resistance comes here is lack of compliance. What is this lack of compliance in the sense? See, for the treatment of tuberculosis, usually it used to take 2 to 3 years. And if we see any older movies, there the main protagonist, that is the hero or heroine, if he or she is infected with tuberculosis, there is to be no cure, so they used to sacrifice their entire life for the family. That was the case earlier actually. And low quality of drugs, if some people are cheating, that is one cause. Then genetic susceptibility also is there. In some parts of the world, people are susceptible to this particular infection. Then overcrowding, climate change, poverty, unhygienic conditions, all these are the causes for infection. And resistance is developed because of non-compliance and all these other things that I have mentioned. There can be MDR, multi-drug resistant tuberculosis also is there. Then XDR is extensively drug resistant tuberculosis also is there. At least about 5 to 10 years back, they were calling it as Bombay strain and all that. That resistant format was identified in New Delhi as well as in Bombay. We had got a bad name for that, and it is due to the hospital environment where this resistance happens. And now it is possible to treat the resistant format also. The first line of treatment, the drugs that are used for the first line of treatment are INH, is isonicotic acid, isonicotinonic acid hydrazide, streptomycin, rifampicin, ethambutol, and pyrazinamide. These are the first line of treatment. These are the first choice of the treatment. I had said that it used to take 2 to 3 years, and I mentioned one particular drug called rifampin. It is obtained from rifamycins. Rifamycins A, B, C, D is there. Rifampin is a semi-synthetic antibiotic obtained from rifamycin B. Because of the introduction of this new type of antibiotic, its effect is totally bactericidal. The treatment regime has changed, and along with other anti-tubercular drugs, the total treatment time has reduced to 6 months. So that is why there is lack of compliance and all that happens. If somebody starts feeling well and if they discontinue, the organism develops resistance. In order to avoid that, actually a combination of 4 different anti-tubercular agents are used, and the duration is reduced to 6 months now, 6 to 9 months. The second line of treatment is ethinamide, PAS is para-aminosalicylic acid, ofloxacin, ciprofloxacin, cycloserine, amikacin, kanamycin, viomycin, capreomycin. These are the different antibiotics which are there, along with the 2 synthetic anti-tubercular agents, that is ethinamide and para-aminosalicylic acid. The synthetic agents are very small molecules that are there, and other antibiotics are there, important being the rifampin or rifamycin. It is called by both the names. Now let us look at the mechanism of action. I said in the beginning itself that it has got a special type of cell wall. If the cell wall can be broken, then you have got control over the growth or replication of the bacteria. INH, isonicotinonic acid hydrazide, is the first line drug that is used. Actually, INH was not the candidate for screening for anti-tubercular activity. It was an intermediate in the synthesis in a series of synthetic drugs, but somebody used INH, and even today we are lucky that that particular person tried that, and it is a very effective anti-tubercular agent. Actually, the mechanism of action is, it acts on dividing cells, that is growing cells. If they are there, then it is active. Actually, INH, now only recently they are saying that INH is the prodrug. That means it itself is not the anti-tubercular agent. It releases isonicotinic acid at the dividing cells by using the enzyme of the bacteria. So depending upon how fast the cells are growing and how much of isonicotinic acid is released, the action of INH is either bactericidal or bacteriostatic. That is about INH. I am not going to deal in detail about the exact mechanism and all that. So then the next compound is pyrazinamide. These are synthetic anti-tubercular agents. Here also it is an amide, pyrazinamide, CONH2 is there. So the amidase enzyme that is present in the Mycobacterium tuberculosis, it cleaves the amide bond, and pyrazine carboxylic acid is released. Here also, and it is because of its liver toxicity, it should be used in hospitalized patients. That is the limitation that it has got. So this also is a prodrug. The next is specific for pulmonary tuberculosis is ethionamide. This also is anti-tubercular, and all these drugs, they one way or the other, they interfere with the cell wall synthesis of the Mycobacterium tuberculosis. Then ethambutol, it is a stereoisomer. You have three types of isomers. It is a dextrorotatory, which is more active than the meso or levorotatory organism. So ethambutol also interferes with the cell wall synthesis. Then coming to rifampin, its mechanism is totally different, and it is actually bactericidal. It inhibits the DNA dependent RNA polymerase chain formation. RNA, in other words, through the DNA, it prevents the synthesis of RNA, and it causes the death of the cell, and it is bactericidal. That is how it is effective. Then the other drug, para-aminosalicylic acid, is PAS. That also is used because you have to have, because of the slow growth and the typical cell wall and the duration that is required for eliminating the organism, they can easily develop resistance. So you have to have so many different drugs, and some of the drugs are specifically meant only for tuberculosis, even though they can be used for other gram-positive, gram-negative infections. Para-aminosalicylic acid acts just like sulfonamide through competitive inhibition of PABA, para-aminobenzoic acid. Then cycloserine, even though it is effective for other infections, it is specifically limited for treatment of tuberculosis only. Then sterile viomycin sulfate, sterile capreomycin sulfate, these are structurally related, and these are cyclic peptides. These are also highly toxic. They cause kidney damage and damage to the eighth cranial nerve. Rifampin is different. This is the one which has dramatically changed the regimen of treatment of tuberculosis. The treatment has been reduced to almost 6 to 9 months. This is a new class of macrocyclic compound. The other two antibiotics that I mentioned are viomycin sulfate and capreomycin sulfate are cyclic peptides. That means amino acid CONH2 linkage will be there, and they have a cyclic structure. But this is a totally different type of structure. It is a macrocyclic compound, but the bridge is across non-adjacent positions of an aromatic nucleus. There is an aromatic nucleus in the structure. Two benzene rings are together, then phenolic groups are there, and the bridge is across non-adjacent positions on the aromatic nucleus, and the mechanism is totally different. These are also called as ansa-mycins. Ansa means non-adjacent positions, and it also has hepatotoxicity, and it should be used, even though it is effective against other organisms, other infections. It is kept only for specifically for treating tuberculosis. Then finally, bedaquiline. We talked about MDR, multi-drug resistant, then XDR, extensively drug resistant organisms. Bedaquiline is a diaryl quinoline which is bactericidal in action, and it forms a complex through which it prevents the synthesis of ATP, adenosine triphosphate, and it is specific for treatment for multi-drug resistant tuberculosis. But bedaquiline, bedaquiline, bedaquiline side effects are it can cause death. Okay, it causes liver damage, and the QT prolongation also happens. When you take an ECG, electrocardiogram, the QT time is increased. That is because of the time lapse that is increased when the electrical system recharge between the beats, or in other words, simple terms, it causes arrhythmia, and QT prolongation takes place and it can cause death. So in other words, what we have learned is there are different synthetic agents as well as antibiotics which have to be specifically kept for the treatment of tuberculosis because of its particular effect that is there, and other hygienic conditions if we can observe, we can effectively control the transmission of this particular disease. And even if somebody is infected with tuberculosis, he or she can be cured today by combination of various drugs. No single drug will cure tuberculosis. Namaste. Thank you.